So the goals, let's review the clinical trends, things that, like I said, we've already done. Review the new and emerging topical medications, and then let's review methods of adherence. You know, that's our biggest deal, and every day we realize, geez, you know, it's great that we have great medicine. I've even gotten to the point of telling my patients, you do know some poor bench researcher spent years trying to figure this medicine out. If you put it in your drawer and don't use it, that is not okay. And we owe it to them to try to make sure that we do have adherence. So new topicals are critical. Yep, you guys already heard. Our families are not liking corticosteroids. If you haven't heard, we've proven it. They're not so happy with the calcineurin inhibitors. I think it's Dr. Sood's soothing talk. Maybe she gets them to do it more than me. But I get a lot of pushback. So we have patients that are suffering unnecessarily. We have patients that utilize unproven and at times harmful treatments, tons of coconut oil, and physicians that may utilize systemic therapies because the topicals either they would not use or were not compliant. I thought this quote was really important as we talk about our topical corticosteroid phobia. It's global, as we're in a global center, and so we know that it's not just the United States, it is across countries, and it is a big problem. But you know what I always find when there's a problem, there's usually a good reason for the problem. And one of those is that, look at this, since 1951 till 2000, we weren't getting any new medications out. It's a long time. And in case the residents are wondering, I was not on this earth yet. So when those topical steroids came out, I was not here yet. So to me, that seems like a very long time. So I get it that maybe now, because the parents are even having unwarranted reasons for not wanting topical steroids or calcineurin inhibitors, but it's pushing us to do more and hopefully learn more and maybe get to better treatments. So we're going to go through the PDE4 inhibitors. Luckily, Dr. Sood let me have Crisaborole, and then we're going to do the emerging ones, which is our hypochlorous acid, the JAK inhibitors, non-steroidal anti-inflammatories such as Benvitimod, and then our microbial peptides. I am not all-inclusive here, and there are tons more, as you can see here, and I wanted to make sure you guys see even this list. And this is where I'm going to the optimism. There's a lot being studied, there's a lot being looked at, so I think good news down the road. So the PDE4 inhibitors, they've been in the pipeline a long time. They're minimally immunosuppressive, so that should be good and make our families feel good about that. It's a small size molecule, so it's perfect for cutaneous absorption. It is rapidly metabolized to an inactive form, so as far as systemic problems, it should be pretty low, and that makes us happy. So just more schematics that you've been seeing, and this is where the PDE4 inhibitors will work. We're definitely decreasing our IL, our interleukins, tumor necrosis factor, and interferon. So what has arrived? Well, it's Crisaborole, and we know it's a boron-based. It's approved for ages 2 and above, and it came out in 2016. It's good absorption with minimal systemic absorption. When they did the studies, the more body surface they applied it to, then it did increase the systemic absorption, but there was no increase in adverse events, so that was wonderful. It seems it works great for pruritus, even better than some of the clinical signs early on. So within 5 days, a decrease in pruritus. And I can tell you when you have a 6-month-old that won't sleep through the night because they're itchy, that mom will be thrilled. And then we have more of the clinical signs looking better at 4 weeks. Patients achieved pretty early success, like I said, with the pruritus, and then when they looked at day 29, they had definitely reduced atopic dermatitis signs. The most frequent reported event with application is the stinging and burning, which is a problem with our younger age kids, as you can see. I'm pediatric derm focused. I'm sure an adult, you can talk them through, they can use it, but once a mom puts a cream on a child and the child acts like it burns, it's hard to convince them to keep using it. So there's other promising PDE4 inhibitors. One is OPA 15406, where you have some ongoing studies right now, and there's been significant improvement in the EASI scores in the first week, and then it persisted through their studies. We also had improvement in pruritus, and the adverse events were very low, and were mainly mild and transient. So oh wait, didn't I already do this one? I did. You know what I forgot, and you guys have reminded me? Bleach. So bleach did come out, and quite honestly, I was there in the midst of it because we didn't have much for long, and I was quite excited. And I remember telling one of my first families, we're going to do dilute bleach baths, this is going to be great. And about a week later, I heard from the pediatrician of that child, And the pediatrician told me, I heard you told this family to put their child in a dilute bleach bath. And I said, yes. And she said, well, I hadn't heard of that, and I went through why we do it. And then she said, that's all fine, but I know this family won't come back to you. I didn't stop. In fact, looked at it quite intensely, and I really felt like it was helping my patients. And then comes along Dr. Silverberg. And so his study is saying, geez, I don't think it's the bleach. But you know what? I can believe him, because I know I just have that up-close view, and it takes looking back, like we showed with those ants, to really understand it. So anybody who's been with me in clinic knows a lot of thoughts go in and out of my brain. It gets a little crazy. So this left-hand upper corner there is what's going on in my head. And the first thing I thought is, these people have not been bathing their children for years, for absolutely years. And though I've asked them to every day, and I beg them to, I think that's part of our issue. So when we do a study and we say, get in the bath, they do it. Now maybe when I said, I'm putting this dilute bleach bath in, they said, oh, that's treatment, I'll put them in a bath. If that's what it did, and it took that, I'm okay with it. We definitely got a germophobic culture, so they like that. I think they'll like that better than I'm going to rub a bacteria on your baby. And then Dr. Google came in. Dr. Google was okay with the dilute bleach baths, and then parents were coming to me asking for them. So good news to some respect, and that brings us to our next emerging treatment, which is the hypochlorous acid, which I think is very exciting, and it really may make a difference. Occasionally when I'm in that room, I ask about pool swimming versus dilute bleach baths, and sometimes I think pool swimming might be a little bit better, and I push for all my eczema kids to swim, because many have this long-held belief that they shouldn't go in a pool, and then I worry that our kids aren't learning how to swim when they have eczema, and that's going to be a complication, so we need to get them swimming. I do think that this has a way to go yet, but I do feel like there's studies that are showing, yes, this is going to make a big difference, once again, in the inflammation that we know we have in eczema. And so it's already there. In fact, I learned about VASH when I had a patient that went to the NIH and had MRSA, and that was what they insisted that the patients with MRSA wash with when they were there. It's been used for our wound therapy, and then as you can see, you probably clean your house with it. If you've jumped in a pool, it's part of it. And then we're also using it as eyelid scrubs. So we may be a little late on the bandwagon here. Definitely some studies, and then just very small, presentations at meetings. But we do have a study right now that's going on in recruiting patients 18 to 65. So we'll yet to hear more about that. JAK inhibitors, JAK inhibitors, JAK inhibitors, JAK inhibitors, right? For everything, anything inflammatory, let's drop it on it. But you know what? I think it is kind of exciting for atopic dermatitis, even though it might not have been as hopeful for psoriasis. I think we've got some news here. Here's what you guys have already seen in Dr. Silverberg's lecture, and this is why that is exciting, because we know that pathway. We know that pathway is causing the inflammation in the skin, and if we can get to that, then we're going to make a big difference. They're small sizes, but it's really good. Once again, they can be absorbed, and that we showed that there was already a decrease in pruritus and inflammation when we did a mouse model. So I knew this was going to happen. My mouth is dry, and these biologics are way too long. Yeah, you guys know what I'm talking about. It's a JAK1/3, and it interferes with the lymphocyte activation and the Th2 skewing. We inhibit IL-4, which is really important, and that just makes a big difference. So the other JAK inhibitor, ruxolitinib, that's being trialed has been used for psoriasis, alopecia areata, vitiligo, and now just the beginning steps of atopic dermatitis and being trialed. So I think both of these are very exciting. We definitely have proved that the EASI scores were decreased. We had early onset of improvement, local tolerability, and really minimal adverse events. So going on to Benvitimod, which is a metabolite of a nematode and is being classified as a topical non-steroidal anti-inflammatory. It will reduce the expression of pro-inflammatory cytokines, so you know that's all part of what's going on here. We have 2 published trials and 1 completed but 1 not published, and at week 4 of the EASI scores, they were reduced to 59.3% using the 0.5 cream, and then that was compared to the vehicle, which was 7.1%. The EASI score, the SCORAD, the BSA, and the pruritus scores all significantly improved. And one study showed this sustained for over 12 weeks. The adverse events were limited to folliculitis, contact dermatitis, and headache. So then getting on to our antimicrobial peptides, which we've already heard a lot about, we know that atopic dermatitis patients have decreased AMP production. So this is very important, and there's a direct antimicrobial action that's been studied quite a bit, and just looking at this as far as for infections. But we know that there's also a modulation of the host's innate immune system. And so Emerging is an AMP gel that's being studied. It's already been looked at for acne and rosacea, and now we have a completed trial for atopic dermatitis and another one that's recruiting. We don't have any published results at this time. I thought this was a nice diagram, and really what it's showing is that AMPs can help decrease pathogens, and then what it does is it will upregulate chemotaxis and the cell differentiation. What's perfect about this AMP is that then it won't cause the pro-inflammatory cytokines. So we're able to stop the inflammation quickly, and it does involve the antimicrobial theory that's associated with atopic dermatitis, which you guys already heard about. So I'm looking forward to the AMPs coming out at some point. Okay, so the last part of my presentation is that you can't have adherence, a treatment without adherence. So just like our peanut butter and jelly, we've got to be careful that way. I feel like we have a long way to go. There haven't been enough studies to look at adherence, and we have so much technology, I think, that can really help us out. So we need better studies, and we need improvements, not only because we know we have good treatments and we want the families to use it, but it'll be very cost effective. Sometimes I think about the number of probably half-used tubes across this country and the amount of money that has been poured out and not used, and we don't want the general population to know, but it's really concerning, and so people need to understand how important this is. So as I was getting prepared for this presentation, I learned about white coat adherence. Now I can tell you, being a clinician, I do believe it happens, but I also have a portion of patients that do not have white coat adherence. I'm positive of that. But for the ones that do, what they have really found is that they want to please us. So sometimes they say things in the room that really aren't true, and they're just kind of, going through the motions. So what we have to look at there is, if that's true, then maybe the closer contact, them feeling like they're pleasing us, will get them to adhere more. So we really need, for close contact. That means maybe a week after seeing them, you give a call. Or there was a study where they looked at calling the families about 4 or 5 days later, and the portion of families that had not even picked up the medications that were prescribed was pretty high. So even just maybe you want to go get that medicine I prescribed. And then appointments. So when we look at studies, we say, geez, you have to come back 1, 2, 4, 8 weeks. That coming back so quickly really keeps in their mind that this is what I'm supposed to be doing, and then you can just keep drilling it into their brains and hopefully get some improvement quick. Because I think that's our other issue with our previous topicals, and I'm hoping the newer ones work faster, but when it's a slow improvement, families just don't tend to put up with it. I was just talking with one of our pediatric dermatologists that, we'll give treatment for cholesterol, and we'll recheck that lab, 3 months, 6 months later, and that's all okay, and we just keep taking that medicine. But when you're looking at your child's skin and it's not getting better day after day, you really want a quick treatment. Interdisciplinary clinics, I think, help a ton with eczema, and then positive reinforcement, especially for our younger children. Finally is education, education, education. And I want you to know, sitting here this morning, I realize why our parents are so confused, because we're still all over the board, and so to educate them on this is extremely complicated. There's studies to show that education maybe would take 2 hours for the initial education, and I really believe that it could take that long. I don't know that you could have families be that involved in the education for that long. I tend to do as much as I can in getting them back and giving them more each time they come so they can absorb it. But one way to help with adherence would be educational workups, workshops, and then finally is the eczema action plan. So families do feel like if something's happening while they're not coming to see you, that they know what to do. And I think when they feel like they have control of the disease process and treatment, then they're better off about that. So in summary, I do think this is very hopeful times for atopic dermatitis patients, and I think we have a lot to look forward to, and hopefully there'll be a lot more topical treatments.